I'll put mine in.
That's it. The manuscripts are due May 19th. Okay, that's 2 weeks after the AUA. I will forward the communication from neurourology. There's a special issue drop down in the submission process that you should be submitting to. There's a form on your table for all of you. Please, please sign that form and list the 3 committees that you're not involved in, 3 committees that you're not involved in, that you'd like to influence with your review. And, you know, there'll be 3 reviewers for each submission, so hopefully we can get this done fast. I can't think of inviting reviewers outside of this room because all of you are here, so it'll make the process much simpler if you just tell me which one you want to review.
Does this include junior researchers or no?
Yes. You guys are budding scientists. You better start working. So without further ado, first I have to, our speaker today, Dr. Lowell Parson, needs no introduction. Well known to all of you. Swati is a pharmaceutical company that has supported our meeting, and its owner wishes to acknowledge Dr. Parsons' contribution, so just bear with us for this 2-minute video that introduces him.
Hello friends, this is Vishal Jajodia, Chairman and Managing Director of Swati Spendus, a 55-year-old pharmaceutical company. We've had the privilege to make a global impact on the subject of BPS. This journey started with Professor Lowell Parson. In 2004, when I initially started on the subject, I had an opportunity to connect with Dr. Lowell Parson. I met him in 2008, and he was very kind to give me a lot of support, guidance, and direction to this effect that today we have made a global impact. We have got the subject open in almost 30 countries with almost 8,000 clinicians associated with us, engaging and discussing this topic and contributing their ideas and experiences from almost 70 countries. We are looking forward to working with you specialists who have taken the effort to come to this Congress. We are greatly obliged to Dr. Badlani to conceptualize and take the effort in opening the subject and bringing all the specialists on this beautiful day over here. I am thankful to Dr. Lowell Parson for mentoring this subject on a global level. And it's a privilege to invite all of you to this conference, Global Consensus Meet. And we look forward to your suggestions, guidance, contribution to making this subject global. And most important, like Steve Jobs said, make a dent in the world again and again and again. Have a very nice conference and all the best.
Thank you, Dr. Parson.
Good morning. It's truly an honor and pleasure to speak to this group. I'm very enthused that there's so many junior investigators here, younger people. And to me, everybody's younger anyway, so it doesn't make any difference. But at any rate, it's nice, and what I want to do, and my goal today is I want the younger well, many of you probably haven't read, you read some of my papers, but not all of them, because a lot of them were published over 30 years ago. Who goes back that far? So my goal today was to review some of the highlights of what I've done over the years. And what my goal is then, I want, when you start a manuscript on IC, whatever, a review or whatever, I want to get rid of the statement that there's nothing known about the cause of IC, because that's not true. I'm going to show you the data from A to Z about what the cause of IC is. So that's my real goal today. By way of introduction, I've been doing research on the urinary bladder for over 45 years. I started as a resident and in the laboratory. And I've seen 10 to 11,000 patients. And when you see that many patients, you get a good gestalt for what's going on with them. And during that time frame, I've done extensive both basic laboratory and clinical research, and I've come to realize that there's only one primary disease process in females of all ages, about 85% of them, they have one disease. And most men less than age 60, say, for outlet excluding outlet obstruction. So that process is, we showed that the bladder has a permeability barrier at its surface, the mucus. And when it's healthy and impermeable, we can all sit here and not feel sensory urgency to go to the bathroom and whatnot. So when it leaks, and it does leak in these patients, I'll show you data on that, then potassium leaks into the bladder wall and generates symptoms, and it kills tissue. And the other issue I'm going to talk about is that heparin can restore the barrier, heparinoids, and prevent the leak. So I'm going to look at all, and then I'm also going to show you that TAM horsefall protein plays a big role, as well as urinary amines. And they are the primary cause of the disease. They injure the urothelium. So I started out as a resident. I wanted to measure back, I was interested in infection, so I wanted to measure bacterial adherence to the bladder because I thought that they couldn't adhere, they couldn't infect. And during our residency, we demonstrated that E. coli does not adhere well to normal mucus, but when you damage it, it does. So over the next several years, when I went to San Diego, I did several studies on looking at it as more of a universal anti-adherence factor. And it did prevent protein, and we looked at radioactively labeled protein, bacteria, and ions. They all were prevented from adhering to the bladder. You could remove them by acid or protamine. Now here's the key: protamine, ketamine, cyclophosphamide, acrolein, they all injure the bladder surface. They're good models for what the disease is all about. And then you could restore them by using pentasam polysulfate or heparin. We used heparin, but heparinoids work in general. The next big issue, we knew it was an anti-adherence factor, and we called it an effective mechanism of environmental adaptation because it really adapts the bladder to all the toxins in urine. The role of the bladder surface mucus in regulating permeability was the next step in the next phase that we went into. And this was an interesting study. But anyway, mucus layers composed of proteoglycans and glycoproteins. They're tied to protein backbones. They're at the surface. They suck up water avidly. They put on what's called, in some specialties like GI, the unstirred water layer. And it's very impenetrable for the most part. It's small molecules. And I mentioned that protamine and ketamine are good models. So this was a fun study to do. I'd done rodents first, okay? We looked at many ways that the mucus controlled movement of molecules in rodents, but I wanted to go to the humans. But what was interesting is it was amazing what people will do for $50, I can tell you that. These volunteers, there were 40 that we looked at, we gave them $50 for a 3-hour study. They had to sit in our clinic for 3 hours with a catheter in their bladder while we did the study. I wanted to measure the absorption of urea under normal circumstances when you hit it with protamine, the mucosa, and then when you restore the barrier with heparin. We did that. So in red, that's the absorption in the normal subjects after 45 minutes of dwell time of a high concentration of urea. They absorb about 4%. It may be somewhat background, but they probably absorb a little. But when you hit them with protamine to injure the mucus, boom, the yellow bar represents, it shoots way up to 25%. And then, that was a 45-minute study. Then we exposed them to heparin for about 15 minutes, and then another 45-minute study of urea in their bladder, and heparin reversed most of the leak. Then we looked at the patients. And here, and the red and the yellow are the normal subjects before and after protamine. And the green represents IC patients, no protamine. We did 50, so it's not a small study. And we did have true Hunter's lesions. In those days, I saw more, but they're very rare. There's probably 6 or 7, but their leak was worse. They're end-stage bladder. They have the biggest leak, so everything fit with what we were looking for. Now, the next big issue was what toxins in urine cause symptoms. Well, potassium was sitting there as the biggest and most obvious cause. Blood levels get to about 7, you die from cardiac standstill, so the body has to get rid of potassium very effectively. Large bowel secretes as much potassium as the kidneys do. And so we decided to look at potassium because the mean potassium levels we found were 75 milliequivalents per liter, 10 times toxic. So it's a big driving force. So we looked first at normal subjects. Start with the normal. I wanted to fulfill Koch's postulates. I wanted to isolate the organism, give it to a new person or a new organism, and generate the same disease. So we took normals. And this time we were looking at sodium absorption versus potassium. And so in the normals, or red and yellow, in the controls, when you put sodium or potassium into the normal bladder, there was no reaction. This is their symptoms. Then when we hit them with protamine, they jump up. The pain fiber jumps up, and the urgency fibers jump up. There's a little bit of response with sodium, but the yellow represents potassium, and you can see there's a marked increase in potassium absorption. And then when we hit them with protamine, it reverses. And we looked at this is an interesting study that Curtis Nickel did. So here's the top, the cells in this, do we have like a pointer that I can't see it anyway? The cells are bound, there's protein-bound proteoglycans, glycoproteins, and the blue dots represent water. This was how we pictured it. What Curtis Nickel actually demonstrated that's so with electron microscopy. So he had a protein to the backbone of the proteoglycans, and he fixed the tissue in the moist state before you dehydrate it for EM. And when he did that, it fixed the proteins in place, and lo and behold, this is what it looks like. That stuff is all the proteoglycans, spaces are water, so it looks just like we thought it did. It was a nice study, Curtis. Kind of amazing that you did that. But potassium absorption in normal subjects. So we looked at the potassium absorption in normal subjects. Before it was the symptoms, this is the absorption. And it was the same as you would expect. The red represents the absorption before protamine. We gave them protamine, and it shoots up from about 0.4 milliequivalents to about 3, reverses with heparin. We looked at patients too, and what I've done here is I put a composite of about 45, now it's up to about 45 references in the literature on humans that had some type of potassium study done. And there were the different types, but then there's also the potassium test. And so there's been over 3,700 people that have had potassium tests, and they were 81% positive. In the control subjects, in about 5 studies, there were 228 patients. Only 3 were positive, and they were weakly positive. They were mine. But the other sites that were doing it, they didn't report any. Well, maybe they didn't do the controls. But at any rate, you can see that the sensitivity is 81%. Specificity is 98.7. And you show me a test that's that sensitive and specific. But what it tests for, this was a test that was for scientific purposes. I was trying to prove that when people have symptoms, they have an epithelial leak of potassium. That was my goal. So what these subjects have is an epithelial leak. I'm not assigning them a disease. So a lot of studies were done in the world literature looking at different symptomatic patient groups. So IC, 81% positive. Normals, 98.7% negative. That's the big difference. Overactive bladders in red because it was done by urogynecologists and I wanted it to stand out. You did 116 subjects, 71% positive. If they had pain, it would be a little higher, but that's positive. It's not a different disease, folks. It's the same disease, epithelial dysfunction. Prostatitis, there are 3 studies on that, 81% positive. Again, when you're struggling to make the diagnosis of what males have, do a potassium test. GYN chronic pelvic pain, there were two studies with 4 gynecologists across the United States in the work study group, and they did normals, they did 50 normals, negative, and in the 2 studies combined, they had 378, 82% were positive. Now, they clinically diagnosed the patients before they put the potassium test, or did the potassium test. 60%, 65% were diagnosed as chronic pelvic pain. Not surprising, because most of the time, they don't know where the pain's coming from. And 22% endometriosis, 11% were diagnosed with vulvodynia, and about 1% were diagnosed with IC, small group. But it didn't make any difference what the diagnosis was. They were all positive. So, as I said yesterday, if you're in doubt about the origin of the pain in a female with chronic pelvic pain, do a potassium test, because the bladder fills and bladder empties, only about 40% of the patients in urology have that. We see a select group, and we never see most of the gynecologic patients. They have urinary symptoms, they have urgency frequency, but they don't bother the patient. Vulvodynia was done by one of the members of the study group, Bruce Kahn. He had a subspecialty in vulvodynia. He screened 122 patients, 84% positive. It's referred pain. Referred pain, allodynia, and if you press on a referred pain site, you cause pain. So pinpointing the vaginal area and the vulva, it's just referred pain. Males get the same, scrotal pain. I call it scrotaldynia. Same difference, right? Radiation cystitis is a disease, is IC, or epithelial dysfunction caused by the radiation. The people that get it, as opposed to the ones that have radiation and don't get it, they're probably normal. But the ones that do get positive potassium tests, and they're all dramatically positive, are probably people that were on the fringe of getting IC. I put some references up here for Dr. Peters, and so I don't want to go over all of them, but Dr. Kuo has done at least 4. Is he here? Because I haven't. Dr. Kuo here? From Taiwan? I guess not. I sort of wanted to meet him. He's done a lot of work in the area. But here was the eureka moment. This is something I chased for 25, 30 years. I was sure that the protamine was a model for the disease. And I was sure urinary amines were the issue. And over the time, we got better and better. We did a lot of studies looking at whole urine, fractionated urine, and it was clearly toxic to cultured urothelial cells. That's what we were looking at. And so the big moment came when we finally started. I got a good PhD in the lab that could do a lot of sophisticated studies on it. So what we did ultimately is you can run a sample of urine through an ion exchange cartridge, which is small, they're cheap to buy, and it'll extract 99% of the amines. We tested them. It does. And so then you can then separate it. When you put it through the cartridge, you get rid of all the cations in urine. Now, urine's composed of cations and anions. They're all in electrochemical balance. Most of the cations are sodium, potassium, calcium. But the only other group are the amines. They're positive, they're amine group. And they will stick to mucosa. So we isolated them, and you can quantify them. We wanted to determine if they're elevated, identify them, and see if they were toxic in bladder culture, 2 bladder cultures of urothelial cells. And we wanted to know if pentosan and heparin would neutralize them, and we wanted to know if TAM horsefall protein. And I'll come back to that issue. So these are the results. We've done at least 4 or 5 studies on this issue. One was a multi-site center in North America. We had 5 sites submitting urine samples for the study. We did not participate in that study. We just analyzed the urines in a blinded fashion. When the study was over, we broke the code, and the results are the same as I'm showing here. Now, this is the total of the toxic amines in urine. And you can see with the controls, it's pretty low. But with the IC patients, it spreads 2.5 times the normal. This is the cause of IC. These compounds injure the mucosa, and IC patients have 2.5 times more than other people. We did HPLC to identify them. So on the top row, you have HPLC performed on 6 normals. And you can see that we use C18 to separate. It separates by charge. So the more highly charged compounds come off first. They're the more dangerous ones in terms of toxicity. I'll show you that data too. And so you can see a nice profile. They've got a big peak, tryptophan. Tryptophan is a big player in the disease too. Tryptophan is the most common or the most ubiquitous amine in the urine. But now on the lower, I've got 6 IC patients, and you can see in the early phase to the left of the graph, you have a whole bunch of peaks, and they're high, and they're almost as high as the tryptophan. So that gives you a relative indication. These are significant, and you can measure the area under the curves, and I'll show you that data. That'll tell you the quantity. So here's a profile in a patient, just representative. And all the peaks are numbered, and the 11-minute peak is tryptophan, and that's big in all of them. And to the I guess your left, you have all these peaks, and they're different compounds. And we identified them. We identified them by putting the urine specimen right from the HPLC into the mass spec. And the mass spec told us the molecular weight, and then you knew what they were. So the ones that turned out to be most toxic are nucleic acid metabolites, which is interesting. They're the most toxic, and when you put them in culture, mix them, they're even more toxic. So we use a toxicity test in cultured urothelial cells to measure their toxicity. So methylcytidine, methyl is 34, methyladenine, methyladenosine is the most toxic of them. Methylguanine is 30%, and then 2-dimethylguanosine is 19, but tryptophan is 22% toxic. So tryptophan is an important player. I'll come back to that issue. So we looked at the toxicity of these compounds in cell cultures, and then we used 3 compounds to see if it would neutralize them. We used TAM horsefall protein, and I'll come back to that issue. We used heparin, we used pentosan polysulfate. They all got the same results. Here's the results. So we use protamine as a positive control. It's in red, and it's 80% toxic. It's on the far left. And before that's urea as a negative control. The cells grow, so it's kind of negative. It doesn't hurt them. And then we looked at methyladenine, methylguanosine, methylcytidine, and tryptophan. And if you look at the red bars, that represents the cells that are just growing normally. And then when we put these compounds, when we put these compounds in, the red shows that there's high toxicity. And then we put the neutralizing agent, either in this one was TAM horsefall protein, and it reduces the toxicity of all the compounds. Heparin and pentosan do the same thing. So the results were that urine cations are elevated in IC patients significantly, nucleic acid metabolites being the most dangerous, or deadly, whatever you want to say. Some of the are toxic to bladder. So elmaron and heparin neutralize them, THP neutralizes them. So that brings me to the last topic I want to cover, and that's TAM horsefall protein. TAM horsefall protein is the most ubiquitous protein in urine. We make about 50 milligrams a day. It's also called immunomodulin. No one really knows what it did or does. I think we know now. I call it the albumin of urine. It binds compounds that are positively charged, and biologically, or protein-bound proteins are biologically inactive. So the reason that we don't all have IC is the Tam-Horsfall protein. It's 75,000 Daltons, and it's conserved in all the vertebrates. Mother Nature would never conserve a protein that much unless it was vital to the function of the urinary tract. And so we looked at this on a number of studies, including a multi-site study from 5 sites in North America where we collected specimens and processed it. But what we were looking to see if there was an abnormality in the Tam-Horsfall protein, and we did find a significant abnormality. So the protein has a glycosylated chain, or has a chain of carbohydrate, and then it has, at the end, it has sialic acid. It's tetraantenary. It has 4 branches. So we measured the sialic acid content of controls versus IC. Controls on the left, they have normal sialic acid. Controls on the right have reduced. That's 35% of the patients. It's significantly reduced. There's your phenotype. This is a different phenotype. They have an abnormal Tam-Horsfall protein, and they may not have elevated amines, but the protein they have can't bind them all. So they injure the mucosa. So that's one risk factor. So at any rate, it's very important that you have normal Tam-Horsfall protein in urine. And we looked at, this is a study where we looked at controls, and you can see that the controls have much more neurominic acid or sialic acid, and the IC patients it's significantly reduced. And when we did molecular weight studies, it reduces the molecular weight from about 75 to 72,000 Daltons. So in summary, IC, we do know the root causes. It's caused by dysfunctional epithelium. The potassium leak causes the symptoms and injury. It kills the bladder. As these patients progress gradually over 20, 25, 30 years, their bladders are constantly shrinking, the muscle mass is disappearing. It's corrected by heparinoids. Pentasam polysulfate is one of them. It's not a glycosaminoglycans because it's a pentose. It's derived from tree bark, from xylan. Urinary amines are the primary cause because they injure the mucus. And again, good examples, ketamine, acrolein. And it's not a rare. Over the years, I've come to realize it's 25% of females have chronic symptomatology associated with their bladder. They're not necessarily seeing doctors, but they have it. So in conclusion, I think once you define the pathophysiology of a disease, it goes from a syndrome to a disease. All of the other diseases that we were talking about are IC in general, IC, BPS, whatever you want to call it. It's a syndrome. It's a collection of patients with common symptoms, no known etiology. We know it. It's no longer a syndrome once you know the etiology. And I summarized a few of the studies I've done, but I'm going to say there were 50 peer-reviewed publications on this topic of bladder symptoms from my lab, and probably 100 to 150 worldwide from other sites reproducing the same things. So I think one thing that probably won't happen here, but one thing what you need to do to look forward is to rename the disease for what it is. Get rid of the IC. You should call it what it is, lower urinary dysfunctional epithelium, or LUD disease. I say lower urinary because it affects the urethra. I think most of us know there's a urethral component to these diseases. Just try to catheterize a male or female that has it. So I think that's pretty much all I wanted to say about that. Can I receive some questions? No? Okay.
So thank you very much for the historical journey through the evolution of this disease, and we appreciate your contributions. Our next up to take us forward is Henry Lai, who talks about research aims going forward in the ICBPS world.
Perfect, thank you. It was my pleasure to talk about research aim in ICBPS. I'm going to frame this in the context of clinical phenotyping of the syndrome. What do we know about the phenotypes? What do we not know about the phenotypes? What treatments do we know and not know about the phenotypes? And how do we move forward together using this phenotyping information to arrive at a state where we can individualize the treatment for ICBPS, or at least improve the treatment outcome of ICBPS in the context of clinical phenotyping and targeted treatment. If you think about why we do phenotyping, one of the goals is to understand the etiology, pathophysiology of a very complex syndrome. Obviously, all of you know it's a heterogeneous population. There's an interplay of multiple etiologies and factors, and those factors can be varying from one patient to another. That makes it so difficult to study. But an even bigger goal and overarching theme behind phenotyping is, can we use this information to improve the care of the patient using the phenotyping? Again, the concept of individualized treatment and targeted treatment based on the phenotype. Now, all this is based on the underlying premise that there are different phenotypes, and I think we arrived at a consensus here today that there are different phenotypes. I don't think there's a lot of controversy on that. But within each phenotype, there's hopefully a specific etiology, pathophysiology. And among those pathophysiology, we have treatment that target that specific mechanism of action to target that phenotype. That's all the premise. I mean, all of these things has to line up for this to work well, and I think we are getting there. Where do we stand today in terms of this? But more importantly, what research can we do all together in this room with all the investigators here today to move the field forward? We really have an opportunity potentially for international multi-site pragmatic clinical trial in the format of a collaborative registry here to move the field forward in this theme. So this is the clinical phenotyping that we put in Campbell's. Actually, we initially only have 4 circles up there, but I added another circle down there with low bladder capacity. But overall, I think everybody agrees there are different types of patients, right? There are the bladder-centric patients. Those are the people with Hunter's lesion that you could see. Those are also the people with low bladder capacity on hydrodistension. There's this group that we never really talk about. Those are the people where we put local anesthetics inside the bladder and the pain improves a lot. So the assumption is that the pain generator is located inside the bladder, and therefore they are also a bladder-centric group that responds positively to local anesthetic challenge with installation. We talk a little bit about pelvic floor-centric people, high-tone pelvic floor dysfunction, tender pelvic floor on either vaginal or rectal examination in women and men respectively. And we talk about the widespread pain, the centralized pain phenotype. Now, the treatment can be tailored based on what we know today in the literature. You could treat Hunter's lesion of fulguration, triamcinolone, TUR, or even cyclosporin A. People that responded to local anesthetic challenge, you would assume that they will respond well to intravesical insertion therapy. I'm not sure exactly what those people with low bladder capacity will best respond to, so maybe we can learn from the group here. My gut feeling is they actually don't respond to most of the stuff and maybe heading to a cystectomy, but I will see what the group has to say. High-tone pelvic floor dysfunction respond well with pelvic floor physical therapy, and we have some data showing widespread pain perhaps respond better to systemic therapy because it's a top-down phenomenon with a hypersensitivity, maybe nociplastic pain or neuropathic pain. They may be the people that you could address the psychological issues with cognitive behavioral therapy. They have more anxiety, depression, catastrophizing, and other issues associated with it. And those are a good group for multidisciplinary, multimodal treatment. Now, the treatment, all the treatment that you see in the different boxes here are available today. None of those are new. They are clinically available. And our strategy is to phenotype these people is already available that you could use today. You could see Hunter's lesion on cystoscopy. You could know whether or not somebody had bladder pain by instilling local anesthetics inside the bladder and see if they can improve. You know about the bladder capacity if you do a hydrodistension of the bladder. You could do a good pelvic floor examination to identify the pelvic floor centric subtype. You could give them a body map and ask them about comorbid pain syndrome like IBS, fibromyalgia, etc., to try to identify this widespread pain or centralized pain phenotype. All these clinical phenotyping, you can already do this today, and it's actually not very difficult to implement. Distension, cystoscopy, pelvic examination, and the body map. They were very straightforward. Now, I'm going to go over one phenotype after another and try to identify some of the research and management questions and what we can do a little bit better, building on what we already know today, from the presentation yesterday. Maybe Hunter's lesion is obviously a Hunter's lesion disease, and maybe people can agree to call this something different. It is probably not a syndrome. It is the true interstitial cystitis. There's cystitis, there's pancystitis in the bladder involving the interstitial tissue. So if somebody have Hunter's lesion, maybe you should call them true interstitial cystitis or IC. If they don't have Hunter's lesion, maybe you should call them BPS. If you don't know what they have because you haven't done a cysto, maybe you could call them IC-BPS. So maybe we can come up with some kind of consensus to name these things, because I think it's very important. We go to meetings in Asia, in Europe, and people calling what we consider to be the same entity with different names. It's so confusing, particularly with some of the Asian nomenclature, honestly, I would say. They have known response to certain treatment, triamcinolone, fulguration, but you got to do this over and over again. I mean, you could do cyclosporin, but it has side effects. Is there any opportunity for improved treatment? We know from some of the earlier data that there may be a clonal expansion. There may possibly be specific response to antigens that we don't know what is causing a bladder irritation. You see that there's hypersensitivity, increased IgE, immunoglobulins in the bladder. Can we try to identify these specific antigens that we don't know yet? If so, can we target treatment based on that? Is IC with Hunter's lesion some kind of immune response aberration in your bladder? Is there some kind of an autoimmune disease? This remains to be studied, I think, and there are opportunity for that in the future. Low bladder capacity, we talk a little bit more about it, but we got 3 bladder-centric phenotypes, or actually more, probably. I mean, how does the low bladder capacity of Hunter's lesion and, response to local anesthetics overlap? I think there's probably people with low bladder capacity with Hunter's lesion, there are one without Hunter's lesion, and I think we need to tease it out a little bit better in how we classify the bladder-centric phenotypes. And what is the treatment recommendation for people with low bladder capacity? Do they respond better with bladder-centric treatment, installation, hydroxyzine, Amaron, hydrodistension, or are you actually identifying a group of people who doesn't respond to anything? Rather than saying that low bladder capacity respond better to bladder-centric treatment, maybe those people don't respond to anything, and maybe they are heading to a cystectomy or other, more aggressive treatment. I think there's data showing is it a subgroup or probably, hopefully, a small population where you go from high bladder capacity to low bladder capacity in a relatively short period of time, so they're rapidly progressing to low bladder capacity from a normal bladder capacity. Maybe we're identifying a group that you need to treat very, very aggressively, and maybe they are heading towards cystectomy or other more aggressive treatment. So those are things that I think we need a little bit more data and on in the future. Pelvic floor dysfunction, you all know about the randomized controlled trial that shows positive response among women with pelvic floor tenderness done in a very specific way. And even before this randomized trial, there was a pilot where they actually also enrolled men, but they didn't see a positive response in the pilot, and therefore they focused the randomized trial on women. Is there an opportunity to revisit this data for the men? Clearly, men have pelvic floor dysfunction. They have tender pelvic floor. It's probably totally under-evaluated. Nobody really wants to do a transrectal examination on the pelvic floor. You feel the prostate, but you're not doing a 360. You're not really feeling all the pelvic floor tenderness. Is there an opportunity to revisit this group of people? Maybe they will respond if what we believe is true. Is there other manipulations you could do? I mean, there are many things you could do besides pelvic floor PT. And the map have this interesting concept that, there's 6 different areas that you could palpate in the pelvic floor. The anterior elevator A9, posterior elevator A9, the obturator internus, left and right. So there's 6 potential points of palpation inside the pelvic floor. And the data seems to suggest if you have all 6 area tender, those people tend to have widespread pain versus 1 to 5 regions. How do we carry this forward? Does that mean that the people with all 6 points of tenderness and have widespread pain won't respond to pelvic floor physical therapy? You won't recommend that? Or does it matter? Are you only going to recommend people with 1 or 2 or 3 areas of pelvic floor tenderness to PT? There's still some of these questions lingering around that I think we need to study better. Now, in terms of widespread pain, we also talk a little bit about the data. I think multiple groups have showed this data. We analyzing a previous randomized controlled trial. It's not a perfect setup because you're really just taking previous data and try to reanalyzing the data and try to see almost like a subgroup post hoc analysis what might work better. It seems that the data at least suggests that widespread pain responds better to systemic therapy, in this case amitriptyline, where localized pain phenotype responds better to localized therapy, the hydroxyzine and BPS. Now, even the degree of widespread assessment in this post hoc analysis, so to speak, is not perfect. They didn't use a body map. They used the Wisconsin pain questionnaire. While this is conceptually attractive, it's very appealing to our mind and to our hypothesis is maybe we have some bias as to what we think the data might want to look like. We need a formal study to prove it. You cannot just move on doing with one study like that, and then add a study is another positive signal from the map showing that, okay, this concept seems to make a lot of sense. That is a prospective, almost like a natural history registry study. But we need to formally study this. This represents a good opportunity for us together today to think about, can we do something together to look at this concept? This might be an opportunity for an international multi-site cooperative registry study to see if this concept really applies to real-life situation when you treat your patients in your practice, okay? So again, I presented this as a very nice diagram, conceptually very attractive, but we know that the clinical phenotypes also overlaps. They are not mutually exclusive. You got people with pelvic floor tenderness that also have widespread pain. You got people with low bladder capacity with Hunter's lesion or without Hunter's lesion. We got people with Hunter's lesion may also have pelvic floor, dysfunction. How does all this phenotyping overlapping playing out still needs to be resolved, I would say. It's not mutually exclusive as presented. And there's these other concepts, right? Should we phenotype in a different way? Totally discard what I've talked about. Can we phenotype to see if they have nociceptive phenotype? That means there is bladder inflammation or peripheral sensitization, versus nociplastic, which is a centralized phenotype, central sensitization, versus neuropathic with certain characteristics that the patient have to make you suggest there's a nerve issue. Can we phenotype using the data from toll-like receptor 4? Can we just simply identify patients as, okay, inflammatory, non-inflammatory phenotype, not just the Hunter's lesion concept? What are we going to do about the data with painful bladder filling, painful urgency? Is that an entry criteria for a registry study, or is it actually phenotyping? How do we use that information? We know a lot about psychosocial factors, all these things that we talk about here. How are we going to use this information? Is that a phenotype? Is that a psychosocial phenotype here? Would they respond to intervention, psychosocial intervention, cognitive behavioral therapy, multimodal treatment, etc.? We haven't built this into the diagram. There's a lot of questions here. We all know the problem about doing a clinical trial on a heterogeneous population, because at the end of the day, the true efficacy of the treatment is masked because there was a mismatch of a mechanism of action to the other phenotype that is enrolled in the overall clinical trial. So the treatment effect is diluted and you don't get the p-value that you would like to see. For example, we know that we have a bladder-centric phenotype, we got a centralized phenotype, hydroxyzine, pentosan, polysulfate probably is good for bladder-centric people. If you do a trial like this, you will see a positive response in one group, but a negative response in another group. But if you mix it all together, you have no idea what phenotype is coming into your study population. Your result may fail because the positive response of one group is being diluted by a negative response on the other group. This is a similar concept. Amitriptyline might be great for people with centralized pain because of the mechanism of action of what it is supposed to work on and to treat. But if you have no idea who comes into your study, then you got a problem. You get negative trial. And that's one of the main reasons why many of the clinical trials that was done before fail. And then we're trying to address it using this concept of individualized treatment. I think you've seen that before. If you tease out the baseline phenotype, you do pick up a signal in a subgroup of people. And we have gone through this data before. So I want to spend a little bit of time, so let's see how we're doing, on this concept of, can we do something together? Is there an opportunity for us to do a multi-site international collaborative registry study to study precision medicine treatment of IC-BPS? We got these phenotypes that we can readily identify in the clinics today. We got these treatments that is available today in your clinical practice, and you may be able to target the treatment based on the phenotype. Curtis talked about treatment outcomes, PRO, and they are readily available. Can we study this together? Now, there are many different ways you could study this together. You could do a clinical trial, you could do a randomized trial. There are many study designs that are available. I don't know how much appetite the NIH for a large-scale clinical trial like this, but this could be a good opportunity for us to do a registry. That means you treat the patient, you do a basic clinical phenotyping on the patients, and then we could, kind of come with some kind of consensus. What phenotypes do you want to identify? How do we identify that phenotypes? And how many patients do we need for these phenotypes? But with those phenotypes, what kind of treatment do you want to target them to? Based on your clinical practice, or maybe based on a targeted way. Maybe some people do a targeted treatment, other people just go for one treatment after another, and you could actually see which phenotype respond to which treatment if you go for a serial trial. And then we collect the treatments data every couple of months, every 3 months. What treatments are you on? When do you start it? When do you stop it? And every 3 months or so, when they go through the registry, with all the investigators, we can assess these outcomes, pain outcome, urinary outcome, GRA, composite scale. And then with all this data from the registry, assuming we have support for a registry and database and analysis, you could look back at the data and see, okay, what phenotype responds better to certain treatment and what phenotype don't respond to certain treatment. Just building this into your clinical practice, but collecting data proactively along the way to put into the registry. I mean, you probably need to have a database support, some statistical support. You may even use machine learning or artificial intelligence to tease out some of those data in this registry. So this is some food for thought for people, of something we can do together in the future, because that will really help to move the field forward. It would be nice if we could do clinical trials with NIH money and doing a randomized thing like that. But I think a registry is another way to go about doing something like this in the future, moving towards individualized treatment of IC-BPS. Thank you.
Thank you, Henry. You're showing us a path forward. So there will be post-meeting some work. We'll plan on doing some surveys, collecting some information from all of you, and then planning these ideas that Henry and Curtis and Quentin are going to talk about today. So next up is the patient advocate, Curtis.
Right behind you. I'm getting up my thing. Okay, is this IC-BPS, correct? Okay, clinical challenges, right there. Thank you. Well, appreciate this. Thank you, Gopal. As I transition into my retirement phase of my life, it is great to be able to present something that has been sort of working on me for the last decade and a half. And who is it? It's the patient. The patient is why we're all here. I'm not going to present any scientific data, Lowell. By the way, I did read all your 50 patient papers. I'm not going to present a path forward into science. Thank you, Henry. That was fantastic. This is going to be sort of from the heart, based on clinical sort of experience, and I want to challenge you. It's, in some respects, I look out there sort of like preaching to the converted, but it's really not. I look out there and I see people who know a lot more than I do about many aspects of IC-BPS, and I see a lot of agendas out there. So I'm more like preaching to the conclave. Now, if you know what that means, you know what I'm talking about. I may never convince you on some of this because of that. So it was back, and I have to start like Lowell did, back in the early 80s when I was putting in DMSO and placebo in patients' bladders, and one of the first RCTs ever performed in urology in IC-BPS. And we had 30 patients followed for 8 weeks with a crossover. And with those 30 patients with a crossover study, DMSO was approved by the FDA in Canada and the US. No real safety data in that study. And that's when I first learned about politics. And the politics, because I had a run-in with the principal investigator, and at the last moment, my name was taken off the paper. And I learned, okay, this could be a nasty business, this scientific field. And I spent my whole career trying to collaborate with people and help other researchers rather than try and be antagonistic, because that was the way it would help the patients. Now, a little bit later, we're going to hear about that from the patient representative. That's the most important person in this whole meeting, is the patients. Listen to her or him carefully. I think it's a her. The IC-BPS patients are why we are here at this meeting. We've got to forget that. Sometimes we get so much in the minutia, in the statistical minutia of our clinical trials, And the main thing is, how can we respond to what that patient representative is going to tell us? So for us, guidelines are important. There are recipe books, and I kind of mentioned that yesterday, and I kind of like that analogy now, that there are recipe books to help patients. Yet the paradox is, we do have evidence for diagnosis and treatment. Every physician has this. It's in the guidelines, or available to all physicians. We all have those treatments available, yet only a few can successfully manage IC-BPS. Why is that so? Well, so I've been in the field for 4 decades, and it's how you use the evidence from the guidelines, using the treatments that are available to you. We have to use what we have. We have to listen to our patients, and we have to have more of a practical interpretation of the evidence, because the evidence is just statistics. Our patient is real. So we first have to understand there's a huge disconnect between what the evidence assessed in the guidelines. And I know, because I've been involved in over 40 clinical studies in IC-BPS, most of them RCTs, and I know that the clinical, what we see in the clinical trial evidence is not always reflected in clinical practice. And it's different because the perceptions, perspectives, and outcomes that patient desire wasn't necessarily what we measured in clinical trials. And then there's a whole bugaboo of, in most clinical trials, we assessed 10 IC-BPS patients for every one that meets the inclusion criteria. So what about those other 9 patients that never got included? So, you know, I've been involved with, not to the extent that Lowell has, but 6,000 patients have taught me the lessons that I've learned. A lot of publications and 45+ clinical trials in the field of chronic pelvic pain. So what have they taught me? Well, one of the things they've taught me is, you remember the very first AUA guideline around 2010, that stepwise treatment. You use one treatment, it doesn't work, you throw it out, you use the next one, going down from 1 to 7. That might work for the odd patient, but it does not work for the majority of my patients. And my patients taught me that because I wanted to follow the guideline back in 2010. But that was the same time that we were starting to produce phenotype, the whole idea of phenotype-directed therapy. And Henry, was so good because I felt like I was in the wilderness for 15 years talking about clinical phenotypes and directing therapy. And Henry stands up and says what we've been saying for 15 years, and it was really, really nice for me to see that. Now, what about the phenotypes that Henry was talking about based on map data and scientific study? That's good for patients in studies, but for me, the patients that present to me in clinic, I see 9 major types of patients, and many of them have overlapping phenotypes. And, you know, with acknowledgement to Chris Payne, who early on told me that, you know, the phenotypes that some of the ones I was talking about, particularly in U-Point, didn't match what he was seeing in clinical practice, and I realized that too. So these are the sort of phenotypes that I actually see in clinic. You can't use this sort of unscientific data in clinical trials, but you can certainly use it in clinical practice. And for each of these phenotypes, I have therapy in my clinic that I can direct to patients. And doing that, I make an individual recipe for every single patient. And that's what we have to do. Now, for us as urologists, we have to be more than researchers to take care of our patients. We have to be a student. We have to listen to each other. We have to be a teacher. We have to teach others what we have learned. We have to be a surgeon, because every now and then we have to do a hydrostatic bladder dilation. We have to do a cystoscopy. We have to do a biopsy, and once in a while a cystectomy. We have to be a physician. We have to put our hands on the patient. And if we don't, we're not really taking care of the patient. And yes, we have to be a uropsychologist. We have to be able to identify maladaptive coping, anxiety, stress, depression, catastrophizing. If we don't recognize it, we're not going to be effectively able to manage those patients. What else do we have to be? We sometimes forget this because we're big-time urologic surgeons. We have to be totally empathetic. One of the reasons is because we're not necessarily going to cure these patients. We're going to be partner with them on their journey to improvement. We have to be gentle. And why do we have to be general? It was mentioned yesterday, many of these patients have had physical and sexual trauma, but we have to examine them, and we have to do that in the most general fashion ever, because we have to be thorough. I've had patients with IC-BPS sent to me who've been managed by other urologists who have not had a physical examination in years, have not had a cystoscopy ever, and so we have to be thorough. The other thing we have to be is hopeful. When a patient comes to us, we cannot be pessimistic. We have to share that hope with the patient. We have to be optimistic that we're going to improve with them as a partnership. And if we don't, we have to be persistent, and we have to keep trying and trying and trying. So my personal trip down memory lane of clinical trials, what taught in IC in particular, 25 clinical trials and over 3,000 patients I've enrolled, and you can see the different trials. It is sort of the graveyard of, in many respects, of IC treatments that fell by the wayside. Many of them, these trials, all of the trials except the PT trial were negative, except patients in the trial did respond, but not to the point, because we put every patient in the trials. Almost everything worked in those trials if it was a pilot or early phase study that a single investigator or a couple of us did. But when we put had the RCT with the hundreds of patients and the dozens of investigators, nothing really worked, except, like I said, that PT trial. So my patients have taught me this approach, and it follows what Henry Lai wants us to do scientifically to prove it. But we can't wait. Henry's vision is going to take years. But we don't have years. We're going to see patients tomorrow. So we have to use the best evidence we have. We have to phenotype our patients, and sure, you can use the way that Henry has looked at it, which I think is very valuable, or you can use a more non-specific looking at patients the way they actually present to us in clinic, the way we do now, and then you use a multimodal therapy directed by the clinical picture that you've arrived at. We have management principles that we sometimes really never talk about. We have to have realistic goals with the patients. In a disease which we can't necessarily cure, the goals have to be realistic, and we have to work those out with the patient. We have to go with the patient, talk to them, and develop for each patient an individual patient-related outcome. What do they want for us to improve their life if we cannot find a pill to cure them? And the patient-related outcomes don't necessarily have to be just pain and urinary symptoms. They can be everything from they want to do activities, they want to sleep better, just have a better well-being. They want to go back to work. They want to be able to have relationships with their partner again. So the patient-centered management principles for every patient, without going into treatment, is a diagnosis. Diagnosis, you have to listen to the patient. We had the whole presentation of an hour yesterday on diagnosis, so don't go into that. But listen to the patient. That wasn't a part of the consensus. Make the diagnosis based on the clinical picture. That was sort of there, and determine the patient's related individual desired outcome. That wasn't there, but that should be there early on in the patient interaction. The three standard interventions for every patient wasn't mentioned in the therapeutic area. But I would think we all consensus agree that educate the patient. She's not crazy, she has a condition. Mindset, the glass has to be half full. Diet is so important for the majority of patients, elimination diet. And exercise is good for pain and it's good as long as it's not high impact. And the treatment, well, individualized, tailored, phenotype-directed therapy. We got to do it now, we can't wait for anything else. We use every tool we have in our armamentarium, and we use not only multimodal, but if we can, multidisciplinary. Now, I do have a slide on research, but I don't have to present it now because Henry Lai did a great section, except let's look at it from the patient's point of view. And you know something? I am probably one of those that sometimes fall into providing that perception, because the perception of patients is that all we really want to do is get grants. And to get grants, we have to do studies, and to do studies, we have to get papers. And then it's a vicious circle that we get into, and we publish or perish. And so sometimes we forget that, publishing papers and doing clinical trials, the real reason we're doing that is to improve the patient's well-being. So I think it's a bit unfair because most of us in the background are doing it for patients. What do our patients want from us as researchers? They do want the high-quality basic and clinical research that we're doing, but they want it to result in meaningful improvement in their symptoms and quality of life. I've had so many patients tell me, because I'm part of MAP, what are you guys doing in MAP? You're producing papers like dozens and dozens, hundreds. How is that impacting me as a patient? We have to remember that. But the latter part of MAP, we can see that the information gleaned is now setting up the path for improved treatment algorithms. And that's what we have to pursue now. We have to realign, or actually align, the researcher, the physician, and the patient goals to improve things. So they want us to move forward. And how are we going to move forward? Those of us in this room who can manage IC-BPS patient must find better ways to teach other physicians. This type of meeting format, I'm so grateful to the organizers, Bob Evans and Gopal, for, this is going to direct further advances in understanding and treating our patients. But this is 2025, and what we're talking about isn't going to probably even happen in my lifetime, so we have to work now to understand the patient condition, to design, implement therapeutic trials, but tomorrow we have to use what information we have to better treat our patients. Now, Henry already presented this, so I won't go into this, but I think it's very important that clinical trials and studies must be pragmatic, as he said. They must be clinically relevant to patient care. And that's studies. We got to make sure now our studies are relevant to patient care, rather than just more and more trying to understand what's going on in the patient. Subjects must be stratified by phenotype, and Henry has outlined the different ways we can do that. Outcomes must absolutely reflect the patient's perspective rather than what we think the patient desires. The multimodal therapy must be evaluated in selected populations, and as Henry lies, there's a lot of challenges in doing that, and we have to incorporate novel trial design. I've mentioned some of them that we've started to use: adaptive design, real-world, N-of-1 studies, and of course the longitudinal registry studies, which I think could be very important. So in sort of summary, as urologists and clinicians and researchers, we must be the absolute best advocates to our patients than we can be. We must be the Michelin stars of urology in managing our patients with IC. We have to look at the condition not from what we think we need to look at it from, but from our patient's perspective. We need to find the recipes for therapeutic success. And we have to use the evolving knowledge and treatment armamentarium, but we can't wait for future clinical trials data to come through or more research. We have to do it now. We actually have the information and data we need. We have algorithms at work. So let's do it. Let's be the best patient advocate we can be. Thank you very much.
Thank you very much, Curtis. Our next presentation is Quentin, and it's a few times we've talked about guidelines. We are not talking about guidelines here. We are talking about getting together and coming up with consensus. So I'd like him to address that. And Haley, is that your talk?
It's up here. At least I loaded it earlier.
Got it. He's got it.
Yeah, perfect. You got it. What do you
Thank
need?
you. So we're going to adjust the direction a little bit here, I think, and start talking about what do we want to do together as a group moving forward. And my understanding of what this talk should be about has changed about 6 times since I've been here. I don't know if you were given a topic, guidelines versus consensus, what type of talk would you do? But I'm among friends, and if it was AUA plenary talk, I would have been rather annoyed, but it was actually kind of fun. So I think the concept here is, as Gopal said, to talk about some of the limitations of the guidelines and also sometimes some of the strengths of consensus. I also found that I'm going to talk a bit about MAP, but I'll finish early because Henry talked a lot about what I was going to mention, but I wanted to highlight a few things. I also think that we can merge this into the next session with Dr. Walker, where we can kind of brainstorm and talk about what we want to do next. So I'm just thinking we have however much time we have during those 2 sessions to talk about these things. So we updated the AUA guidelines in 2022, and you can see myself and Henry and Deb Erickson were the main clinicians on this update. And you know, the concept with the guidelines is they reflect the current data. Every time there's an update, there's a methodologist who looks at the world literature and says what's been new since last time. Guidelines are very focused on randomized controlled trial data, and so I think some of the frustration is that they tend to ignore what might be considered by us high quality data, or data that we use in our practice because it wasn't an RCT, for example. So we have 26 statements, and you can see I've listed them from what I'd consider, you know, no data to strong data. And, you know, of course, clinical principles, well, you should do a physical exam and take a history. Like, there's never going to be an RCT to prove that, right? So some of these things, those are called clinical principles. So that's fine. We had 10 of them. Expert opinion is just what it says. We think this is the right thing to do. And there might be a way to try to prove that, but those can also be difficult. And then we have options, which you can see, those included all of the oral meds, bladder installations, hydrodistension, botulinum toxin, neuromodulation surgery. And so now we get into the therapies, and these are all saying, well, you can do them, all the evidence to support doing any of them is not great. So there's a potential opportunity for improvement with better evidence. And then we have recommendations, which are basically, we think that there's good data for these, and then standards, where there's really good data. So let's look at those. What are the recommendations and standards? So the recommendations are you should treat Hunter lesions if they're there. Don't give systemic therapies, and don't do high-pressure, long-duration hydrodistension. What are the standards? Standards are you should offer PT if someone has pelvic floor muscle tenderness. And I think there's perhaps emerging data. You could offer PT to any patient with IC and they might benefit, but currently the trials have tended to be limited to patients with documented pelvic floor muscle tenderness. The other 2 standards are don't give intravesical BCG and don't treat with long-term antibiotics. So 4 of the 6 strong statements are basically don't do these things to the patients. So that's where we are when we use a guideline approach. An example of consensus is these NIDDK criteria that we are aware of that I think we all agree need to be updated. But I think, you know, rather than focusing on that side, just think about, you know, how this happened. Well, as I understand it, you know, Phil Hanno's not here, but I think Phil Hanno and Alan Wien, as I understand it, were in the backseat of a cab going to a meeting, and they said, hey, we were supposed to come up with criteria, weren't we? And so they got a napkin out and a pen and drafted them. Now, that may be an urban myth, so to speak, but that's what I understand. In any case, so that wasn't based on data, so to speak, but by the world, the IC world, agreeing that these were reasonable and developing a consensus, it did advance the field. Because we could all at least say, okay, we followed the NIDDK criteria to do. And so I think that I could stop the talk there and move on, because I think that was kind of the concept, really, is that as we think about what we're going to do moving forward, just keep this in mind. Or, you know, sometimes in surgery we say the enemy of good is perfect, and sometimes as we kind of develop whatever it may be, there's always, yes, but some patients aren't this, or there's always areas that aren't, you know, exactly fit the mold. So maybe keep that in mind. So I wanted to talk a little bit about a few topics, and like I said, some of these I will skip through pretty quickly. So the first is, you know, back to the definition for for IC. So I think from a US standpoint, one of the problems is in a number of the problems related to the FDA. And I'm not here to bash the FDA, they have their rules, but the fact is they are very wed, as I understand it, to the NIDDK definition of IC. And so when someone does a trial through the FDA, they require that all of the patients meet those criteria. Now, it's interesting because the NIDDK criteria require cystoscopy with hydrodistension in everyone, and also urodynamics. Now, most people, when they say we followed the NIDDK criteria, they ignore the urodynamics. I don't know if you've noticed that, right? So we're already kind of not following them, but we say we are, so it's a little weird that way. But in any case, there can be barriers because cystoscopy with hydrodistension has a cost to it, and urodynamics does. And if that hasn't been done as part of clinical care, then you get into the issue of, well, how are we going to pay for those expensive studies? And I've seen that be a big barrier. But my impression, again, I'm not speaking for the FDA at all, but is that unless there's a change to this, that they're going to continue to say, we need you to follow the NIDDK criteria. So, you know, how would we do that? Well, I think the fact is that would require a consensus, you know, because we're not going to have data for all of these. We certainly, there's new information out there that we can all look at, and we presented that in our diagnostic group summary that we could use to update. But, you know, I think the point is it would end up being more of a, what I call political process. What I mean by that, political is motivated by our current beliefs and experiences rather than, let's say, RCT data. So that's one problem that I think we could try to fix. I wanted to just highlight the questionnaires. This has come up before a little, but as we think about questionnaires, remember that there's two types. There's, you know, case definition type of questionnaires where we try to, you know, do our best to use a questionnaire to identify a disease or not. And that's where we use data, sensitivity, and specificity. How good is our questionnaire? And I think that it's important when we do these calculations, it's not really helpful to compare our questionnaire to patients who are asymptomatic. I mean, I can make that questionnaire, which is, do you have pelvic pain, yes or no? Anyone with IC is going to say yes, and controls are going to say no, and the sensitivity and specificity are going to be great, right? What we need is ways to discriminate between patients with IC and patients with overactive bladder, vulvodynia, endometriosis, other, you know, confusable disorders, so to speak. And none of them are going to be perfect, but that's kind of the process. And then for patient-reported outcomes, we've talked about questionnaires that really assess the severity of symptoms and then can track treatment over time. And so some of the data we get from that are things like minimally detectable differences or clinically important differences. To what degree, if a change of 3 points happens, is that meaningful or not? And there are ways to calculate that. So we've talked about the Rice case definition, which is an example of one. I won't go into that. I will talk about the PROs a bit. As Curtis brought this up yesterday, and he's absolutely right. You know, the FDA has rejected all of the existing questionnaires that have been developed to use for IC studies. And so we are left with global response, Likert scales, like we talked about yesterday, and they may be fine, but it seems a little uncomfortable that we're using kind of general outcome measures like that versus IC-specific ones, and maybe we are missing something in our outcomes by using those general that we could do better if we had a specific, you know, IC-focused PRO. And the problem is to do that requires starting from scratch, getting focus groups together, you know, getting data from the patients and moving on. It's possible after doing all that, we'll end up with a questionnaire that looks virtually identical to the ones we're using now, but that's where it's a political process as much as it is sometimes data-driven. So this problem can be addressed, but as Curtis said, it's going to be expensive and require resources. So a couple brief comments on phenotypes. So I think that certainly within the map, we've heard about this. I won't go into details of the specifics. One point I would make is that the map only had 28 patients that we knew had Hunter lesions. There may have been others. Some of the patients were recruited and hadn't had an obvious cystoscopy that we could find, or we couldn't get the results to it. So, but the point is, the map really isn't going to add much to our understanding of Hunter lesion patients. So there's an opportunity, if you will, to develop complementary studies that maybe focus on 100 lesions. Larissa brought this up yesterday, the difference in what we saw when we did psychometric analysis of the questionnaires is that some patients had more predominantly urinary symptoms, others more pain symptoms. And these did not correlate with clinical diagnosis, because it'd be tempting to say, well, of course, the prostatitis men, had the pain and no urinary. It didn't correlate at all. And more importantly, perhaps, as you followed the patients over time and they were treated, their urinary symptoms and their pain symptoms moved differently. And so the concept here is, like we've talked about, there are some patients that maybe don't report pain, and if you ignore them, you're not addressing a certain subset of the patients, they're not allowed to be in the trials, and there may be treatments that work better for the urinary symptoms than the pain symptoms, and that was kind of the concept that we were endorsing here. Then, very importantly, we've talked about widespread pain, and patients with widespread pain tend to do worse. I want to highlight a couple things. This is the body map we used. Just be aware that we started with, I forget how many regions, like 78, and each one they listed how severe the pain was. We administered it weekly times 5. We had all this data. We had to then figure out, well, is it stable weekly times 5 or not? Is it a stable measure? Does it matter if you quantify the degree of pain? At the end of the day, it didn't really matter. And the point is that we boiled it down to so there was a lot of work behind this, I guess is the point, to get to this very simple body map, which works fine, and you can just do it at baseline, and you don't have to repeat it 2 or 3 or 4 times because there's a lot of variability, and you don't have to ask about how severe the pain is when they check it off. Just if they have pain there, it works enough. So part of that process is saying, well, we have all this data. We don't want to just publish it and say, here's what you should use. We want to have data that says, here's the way you should use it and here's why. And that's a little bit difference of the process when, at least within the map, to try to do a deep dive, if you will. So when we recommend something, we feel good about it. And you can see here, widespread pain was 3 regions outside of the pelvis. And that was about 25 to 30% of the patients. Now, I want to change a little bit to the concept of nociplastic pain. Okay, so when you're a pain specialist, or they talk about nociceptive pain like arthritis, tissue damage, neuropathic pain like diabetic peripheral neuropathy, right, and then nociplastic pain, which is what we're talking about here. And typically fibromyalgia is the one that people talk about. Pain arising from altered pain sensations in the absence of tissue damage or neurologic disease. And it's often in multiple areas. It's thought to be due to amplified pain processing or decreased inhibition of pain stimuli at multiple levels in the nervous system. And patients who have nociplastic pain will have increased pain response to painful stimuli, and they'll also have a pain in response to normally non-painful stimuli. Risk factors include female sex, early life stressors, trauma. Does that all sound familiar? Not all of our patients, but the point I'm making is I think one of the things we are, proved in MAP is that many of our patients with IC or chronic prostatitis have nociplastic pain. Concomitant symptoms, fatigue, poor sleep, et cetera. And then the treatments tend to be non-pharmacologic, treatment of comorbidities, centrally acting meds, and they tend to do poorly with opioids. So I think we've talked about widespread pain. I think really the term is nociplastic pain. And this is not, like I keep saying, unique to our patients, but I find that if we prove that our patients have it, then others will feel more comfortable taking care of these patients because there are similarities, because we need that. We need help from our colleagues. And also, if there's a fibromyalgia treatment breakthrough, well, it makes sense that we could use that in our patients, at least try it. And Dan, I think, brought an example up yesterday. I wrote it down. Because the other point is, as Jen said, we need more systemic therapies. Like, okay, well, Elvo failed, now what? I feel the same way. Like, we need some other categories and things. So, okay. So back to widespread pain. We've shown in retrospective studies that seems to correlate with treatment response. I will tell you that this is an example of something that's Never been demonstrated in any chronic pain condition before. So one of the things I try to highlight is, we've sometimes helped out the IC world, but we've also sometimes helped out the broader chronic pain world in perhaps understanding things. So I'll skip over this because you've seen it 30 times by now. And then this is the other data, which I just want to highlight, that during MAP, we could not dictate therapies, but we could ask the patients, did your doc change your meds or your treatment? And then if they said yes, before they started the therapies, we had them come in, do a bunch of tests, phenotypes, et cetera, and then follow them. And the hypothesis was that patients with widespread pain would do better with systemic therapies, and patients with localized pain would do better with localized therapies. And this is in PRESS, neurourology and urodynamics, but that's what we found. Right? And so it sets us up, again, this idea of nociplastic pain as a potential important phenotype moving forward. There's talk I heard about, it would be great if we could have a simple, standardized way to tell urologists how to do a pelvic exam. And so we developed that as a 6-point, so it's just you go around like a clock, and score it 0 to 6. And we, worked with a physical therapist. We had, one for men, one for women in terms of the, specifics of it. You can see it was published a few years ago in Journal of Urology. So one thing I want to highlight is just, so moderate or high pelvic tenderness which was about 70 to 85% of the patients. So a lot of people had it. You could see if they had high tenderness, which was all 6 sites. So we separated that, all 6 sites called it high tenderness because they looked different. They tended to have more widespread pain and more neuropathic pain. And so again, about 20% of men, 28% of women. So my take on this is, if you have tenderness everywhere, you might want to consider physical therapy plus a systemic agent. Neuroimaging, we basically showed that, there are central abnormalities. And so that somewhat transitions this from an idea of a syndrome to a disease model. This would be a fascinating 2-hour talk, which I'm not the right person to give, but one important thing is, before the MAP, no one had ever taken fMRIs across multiple sites and merged them. And it was a big effort to do that. And so there's an example of, something that MAP did to really expand the field, so to speak. The other important thing is, brought up the HPA axis and inflammation yesterday, and so that's been demonstrated in our patients in this study where patients with widespread pain, if you take peripheral blood white cells, you stimulate those with LPS, which specifically stimulates toll-like receptors, they release more cytokines. And those that do that tend to have more widespread pain and more sensitivity to pain testing. And so it all kind of comes together that at least some of the nociplastic pain concept may be due to inflammation, and it gives us another target. So with that, I would just say that, so there's a MAP website, and within that, there's something called Data Direct. No, it's not called Data Direct. I'm forgetting the name, but I'll think of it. In any case, there's a way for you to access, anyone, to access the MAP data at a minimal level. But if you want to know how many male patients had this test or that test at baseline and then at 6 months, you can get that information as you are then writing a grant. And all the data has been deposited at the NIDDK repository. I'm not the expert on what hoops you have to jump through to get it there, but I think if you just provide a proposal, you can get it. I've heard sometimes you need to have grant funding, but that's something I can't answer, but it is available. So, if any of this has spurred, there's certainly plenty of questions we haven't answered. So I guess I'll stop there. The next is to transition into kind of ideas and thoughts about moving forward. So I don't know, Gopal, is that kind of what you wanted, or are you pissed off at me?
It's leading to what I want. So Steve, come up. We are going to have them up here, and get a chair, both of you, so you can sit down and chat with people.
I had one slide.
Yeah. Yeah. So the goal is a method to go forward, right? So you're all here, clearly interested in being here. So the follow-up will be that we will create a survey after the AUA to send it to you to get at least a consensus answer on some of the obvious questions. We are striving hard to find a way to create the central repository for the data. It is not an easy process, and the cost, et cetera. There's some promise of funding, and my appeal to some people to come up with some money for support. But until, don't worry, I'm not asking any one of you. So the goal is to find, and the obvious sources are societies and organizations that may have that access already. So I don't know, I don't see Mauro this morning. ESIC, oh, hi Mauro. We need to come up with some idea of which organizations are willing to support a central registry, which is clearly a cost. I don't know how rich ESIC is, or otherwise we have to reach societies like SUFU or OGS or ICS. Again, that becomes hard because this is a much smaller group in the overall organization. My third, these are thoughts at this point, and is AUA.
Thank you for this invitation. Just at the breakfast, we are discussing with the two members of our board of the ESIC, and the idea is great, absolutely. It's one of my ideas since many years ago. The problem is, as you defined precisely yesterday, the funds, because obviously an international registry means the funds, but mainly the inclusion criteria and the homogeneous data. Yesterday you said with the AI probably some different patient may be included also in a different evaluation, but for me, but not only for me, for honest researcher, the data and the global patient should be as much as
Maura,
homogeneous as possible.
I'm not disagreeing with you. I'm agreeing with you.
Okay.
But
okay.
Before we get to the data, we have to establish the registry someplace. My question to you is, does ESIC have ability and funding to create such a registry? My thought is,
yeah.
yes?
We are involved in the ERN. ERN is the European Reference Network, and is a European organization organized by the European Economic European Committee, and they strongly wanted to have an international registry, and this could be a possibility for all people interested in IC worldwide, with including obviously the AUA, the MAP, and as well as the ESIC in the first position. And we can speak and we can cooperate among us.
Okay.
For us is absolutely, I'm extremely in favor. Also, Rob Maldwin, that is Vice President with me, is absolutely in agreement, as well as the other board members.
Okay. So that's a thought we'll follow up. The alternative is Henry is taking over as a research coordinator at the AUA, and the science and data and quality, there's Aqua there already. We can explore with them the possibility of housing the data after we discuss with you. So to bring everything together forward, the two stars up here, just to create some ideas as to what small projects we can at least agree on early on, go forward, et cetera, and what resources we can share and examples. Both of you can address that, please.
So I just wanted to start, this was a slide that Dan Vickery had sent. It's interesting. So you can just see these are data from RCTs over the last 15 years, and I think the point was, if you look at the number of patients that were recruited per site, it's pretty low. And I think it just, highlights the difficulties with recruiting into randomized trials. We, can have a discussion about that. I don't think that the vision or the reality is that this group is in a position to do an RCT. And I think the point is that, we want to kind of start small and limit what we're doing to kind of see how it goes at first. But Dan, did you have any additional comments?
No, I think the very first slide, I can't remember what the speaker was, but they listed all the comorbid conditions and all the confusing conditions. And by the time you put all of those in as exclusion criteria, you probably have to get rid of the comorbid conditions, and definitely the ones that are inclusionary, like infection.
Can you speak in the microphone, please?
Who did the first section?
Oh, that was us. The first session on the diagnosis.
Thank you. Yeah, diagnostic, Glenn. It was Glenn presented. Yeah, Glenn. So by the time you said the comorbid conditions, I believe, and then the ones that were exclusionary, so those all, in a clinical trial all need to be exclusion criteria. So you've essentially removed the comorbid group. And, so as you continually add things that you need to do, we've got a cystoscopy, complication that the FDA wants cystoscopies, and it's difficult to get patients who are in pain to want to do a cystoscopy if otherwise they're not indicated. So it's simply a matter of every time that you're going to add something, it's going to make it harder and harder to conduct the research. And that really is just the background to show you it's not just, it's every single company that's tried is spending incredible resources to get sites up and running, and the data is just not turning out well. And a lot of these were very promising products. So I don't know if the problem is because the products don't work, or it's because we can't get the research done. And that's really what it really needs to be addressed if we're going to figure out how to sponsor innovation in this condition.
Thanks. The other comment I'd make is there were talks about, ways to improve clinical trials, and there's a paper that is coming out shortly in Nature Reviews Urology. Elisa Stevens from Penn, who's involved in the MAP, was the first author that highlights some of the things that were learned in MAP about developing clinical trials for IC and chronic prostatitis. So just keep an eye out for that, because I think that's in line with some of the discussions that we've had.
So if Curtis can help me. So my recollection is in the NIH trials, we did not exclude the comorbid conditions, because so many people have them. So that would be one thing I would say, is that, I agree with UTI as an exclusion, but I would argue they would not be an exclusion criteria.
So I'm going to make a proposal to see what people think. Is what about we focus on the Hunter lesion patients as the group that we start examining. I mentioned that the MAP really, I don't think, added much to the literature for that, so it would be, in that sense, complementary, if you will, to those studies. Plus, as we talk about comorbid conditions, well, that makes it a lot easier, I think, because, if they have BPH as well, but they have a Hunter lesion, well, I think we would probably not worry, that the BPH is causing their pain or whatever. It just clarifies things a bit. So I want to know what people think about that. It's an example where, we have a handful perhaps at each site, and then we combine them, pretty soon we have a lot more than anyone's ever reported in the literature. So, yeah.
I think that's a great idea, just looking at sort of funding or lack thereof. Would you, what about starting with something prospective, or, just collecting data on the patients, since there were small numbers in MAP, and then from there? So that could almost be something done with minimal funds, right? You could, I have 10 patients, right? You could do that kind of small, like I guess,
you would,
case series.
often the expense is, you need a statistician, you need a data core of some sort, and they have to be paid some amount. So that's an expense. Depending on the number of, the amount of data we're collecting, sometimes having a research coordinator at a site, but that's not always, necessary. So I know the OGS and SUFU have research groups that the model is they pay for a data coordinating center. We could get fancier and talk about doing biopsies. I think that that could legitimately be something that's done as part of regular care. You then do an extra one and send it to somewhere, right? We'd have to figure that out to look at things. So that would be extra, and I think the overseas sites, that might not be possible just because of the logistics. But you could have different levels, if you will, of participation, and yeah.
The SUFU Research Network would be a good mechanism.
Yeah, I think we could parallel it, or,
Right.
yes.
I respect why you're suggesting that, but I actually feel oppositely. I think the difficult thing about patients with bladder pain syndrome is figuring out what it isn't. So Hunner's lesion, we all feel reasonably comfortable that we've identified something we can treat, and the difficulty with these patients is what else it could be. So I would start more broadly, trying to characterize all the things that we've talked about over the last 2 days, the pain mapping, the confusable conditions, the coexisting conditions, and sort of create protocols for what to do with those patients. But that's a wide net.
I think that, well, these are all things, but I think that that certainly would be an ultimate goal. I think one thing is sometimes when you start with something that seems like too easy, if you will, you learn how hard it is, and you learn from that before tackling something that's a lot more difficult and broader than. But I think certainly we struggle the most treating the patients you're describing. But anyway, the thought was let's start with something where we feel reasonably that we don't have to spend too much time going over the criteria, but then learning the process. And then the next step is addressing that large group so I view it as a process where that's the ultimate goal. But that was the idea. So I agree with you. It's just how do we get there? And I worry, I've seen too many things. If you start out too broad, it fails because you're asking too much of everyone. And we don't have the money to make this where we can get a lot of money. I mean, we don't have, so you have to kind of rely on volunteerism, and that if you do too much of that, it goes away. That's
maybe decide on minimal data to characterize on those Hunner's patients. That would be standard of care for a clinical scenario as well.
Yeah, and then we could pass. That's exactly the thing. Then you said we know how to do that. Now we expand it to more patients. Yeah. I think you.
Oh, okay. I have a question on, you mentioned in a 10-year MAP study, only 28 patients were Hunner lesion, Hunner IC. So that 28 was what percentage of total IC? How much was that? How many were total IC? If that 28 is such a low percentage, that may explain why all this trial fails, and only thing that works is physical therapy. That in the morning session, Curtis Nickel mentioned, physical therapy was the only positive trial, everything else failed. Because then you may not be recruiting Hunner IC patient in most of the clinical trials. Is this possible?
That's important. I think the important point is we need to be very sure that when we recruit into any future IC trial that we know how many are Hunner lesion patients. And there was some difference of opinion about whether in MAP 1 to really do that or not. We agreed to do it in MAP 2. So that was part of the reason. And there are other reasons I mentioned. So we don't know. I mean, the reason some of the trials failed, you're right, they could have included some Hunner lesion patients we don't know about.
But my question was in MAP, how many were non-Hunner?
I think we had 600 to, I mean, between the two, there was some overlap. It may have been 800 total IC and prostatitis patients.
Thank you.
Hi. I want to share some of the experience that we had in the Netherlands, actually, about all this thing, because I think it's looking at all these failed trials and the RCTs and everyone hanging on to these RCTs creates the same problem. We don't get enough patients. So the other methodologies that Curtis already mentioned is like a crossover trial. So an RCT doesn't teach you anything about differences in heterogeneity between patients because you compare patient A with patient B. So it means we need much more focus on crossover type trials. Most drugs aren't curative, so you can do a crossover with a placebo and so on. It recruits better because everyone gets treatment. If you do multiple crossover, like an N of 1 trialing, that actually needs sometimes less than half or 1/3 of the patients required to get level 1 evidence. So methodology, there's so much to gain, and the problems that we have with the Dutch authorities was getting them convinced of honoring an aggravated N-of-1 trial. It's a multi-crossover type trial, which just needed 30 patients in 100 lesions patients. So we now set up a trial, and it's just finished inclusion, the Gatsby trial. We're looking at gag installations for 100 lesion patients, cystoscopy diagnosed and followed up. And it just uses 3 treatment periods, and it is actually a combined RCT. It's powered for an RCT. Got 72 patients enrolled. We just finished enrollment. And we continue it with the multi-crossover design, also to convince authorities to compare an RCT with a crossover, just a single crossover, and a multi-crossover trial in one single trial, also to convince them that these smaller amounts can also show you the same level 1 type of results that you can get with an RCT. Even if you can also, with the heterogeneity, you can actually detect subgroups in which it works, because each individual gets and placebo and 2 treatment trials. So it's actually for enrollment and scarcity of patients, you can actually use these types of methodologies, and that study is just finished inclusion. So I hope to be able to the next consensus meeting that we say, okay, we'll stop with RCTs and just do multi-crossover trials with just, well, if you do, especially for drugs, if you do like 5 or 6 cycles, you can do aggravated N1 trials with 10 to 20 patients with level 1 evidence. And these are the things we need to be aware of, that these methodologies exist, and we should use them, because it's an endless list of failed trials, and there is options out there. So please.
Thank you.
Back to the registry thing. I agree with you, and I do like focused prospective studies in small groups of patients. You can answer questions. But this registry is an opportunity for us to look bigger than this. Let's go for the sky. Let's not at the start limiting ourselves and shooting ourselves in the foot and be criticized in the future for not including all ICBPS patients. By doing a registry that only includes 10 to 15% of our patients and excluding 85%, I think we're making a big mistake. We have to include everybody. Even if it dilutes a little bit, it'll give us actually more information. And it'll give us information regarding the Hunter lesion versus the non-Hunter lesion. So let's look big if you're going to do this, totally understanding that prospective, focused, small studies are great, but this isn't. This is the chance to encompass everybody and look at the entire group. And I know the funding, the statistical, and the logistics are all going to be problems. They're problems that can be solved, and we just need to solve them. But let's not ignore 85% of the patients.
Yeah, I just wanted to speak to the registry question. So about 10 years ago, we started recruiting patients here at Wake. And our one inclusion criteria for this particular registry was the patients were scheduled to undergo hydrodistension. So fast forward to today, we have 750 or so patients enrolled. We have tissue from everyone, we have clinical data from everyone, we have questionnaire data from everyone, we have sort of semi-phenotyping from everyone, but we have in our cohort about 70 to 80 patients with Hunter lesion. We have biopsy from all of them. We have peripheral blood from all of them. We have urine from about 1/3 of them. We just started collecting urine recently. So anyway, we've created a registry here, just as an example, of almost 800 patients across the ICBPS spectrum, and those are just the ones that are undergoing hydrodistension. We have another registry where we're starting to collect the other several thousand patients that are seen at Wake Forest that are not undergoing HOD. So just as an example, we have that stood up right now. And I don't know if the point is to identify patients for clinical trials or to get a better understanding of mechanistic mechanisms underlying the subgroups or whatever, but we have opportunity now, and we mine this database continuously, looking for different things and different correlations. So just as an example.
As a non-urologist, I have to ask a question that might be a little bit heretical, but with all this talk about Hunter's lesions, it's based on an assumption that non-pain controls never have them? And are we fully confident of that?
Well, we do a lot of, urologists do a lot of cystos for many different reasons. And I guess I don't think I've ever seen a Hunter lesion in someone who I'm taking a stent out after or whatever. So, I think the answer is no, they don't exist without pain, because I don't know, has anyone seen a Hunter lesion in someone who's not having pain?
No? Okay, just had to ask because I've never heard of a study that actually shows that rate is zero. So,
So.
Okay.
So I think, I mean, having kind of tried to, you know, have databases and stuff, you know, music has been very successful in Michigan. There's been an incentive to be involved in music with, you know, uplift from, you know, insurers and stuff. And I think it kind of brought a whole group of people. And I think Michigan's done a great job at kind of coordinating that whole thing. I agree with Dr. Day and Curtis in that, you know, we don't want to get, you know, we don't want to ignore the 85%, but I do think the value in starting with Hunter's lesion is to set an infrastructure for us to all work together, just like in music when we did our initial thing on like imaging with prostate cancer. You know, something very focused, very small, so that you can kind of get people into a consortium in a way to share data. And as you show success, you're going to be more successful in getting funding to go for the bigger patient population, because that is an overwhelming thing to think about as far as with those numbers of patients, all the comorbidities, the amount of resources it would take for each of us to be able to collect the appropriate data and send to a database. So I do think we should start small, because if we try to go big right off the beginning, we may fail and then we're going to lose our opportunity. I think there is value in figuring out Hunter's lesions. I think if we put all of ours together, I mean, I certainly have over 100 of them in my practice. I think it would be very helpful in understanding that. But I think what it would do is it would give us a starting point to be able to kind of work together and figure out a way forward. So I would be supportive of limiting it initially with the goal of expanding it. And I think that'll give us value to ask for funding if we say, look at how successful we were, like we were with music. So that's my thought.
Thanks.
The only thing I can comment on from drug development is I can't think of a single instance where anything that's done with a scope or radiography or any other visual representation isn't scored in a blinded manner by an independent group that actually looks at all the pictures and all the radiographs and actually agrees on what it is they're actually seeing. So I believe that trying to use cystoscopy at the individual investigator level will not be successful. It will need to be read blinded manner by a committee.
So I think you're getting at one of the, so the question is, I think is, can we agree on what a Hunter lesion is, which is sometimes controversial. And I suppose we could try to get people to take pictures of them and send them in, and you know, that would be a way to address that, whether it's through a central review or just to say, boy, do the Hunter lesions in some part of the country look a little different than in others, and what does that mean? But so that might be one thing that, you know, it would be a unique opportunity. Many times these reports are at a single site, and it's not common to have multiple sites working together where you can ask questions like that. And so that might point us in that direction, because if they look very different by some unblinded person, then it might raise the question of, are we treating the same thing? I don't know. So I mean, these are things like, certainly there's a lot of interesting things we can talk about. And I think certainly understanding what the goals are and what the hypotheses will be is a very important early question. But I guess I'm getting the sense people think it's worth pursuing, I guess, which was kind of the goal. Sanjay's going to say it's a terrible idea.
No, not at all. So I agree that having a more focused, small study is the better way to start. But what I thought was when you're doing a study on Hunner lesion, it automatically implies that you are scoping these patients. So why not just expand it a little bit to make it cystoscopy in patients presenting with bladder pain? And then that would yield you two sets of patients, the ones in whom you do you follow the biopsy protocol, for instance, and the rest in whom you have the Hunner lesion related information. Just a little bit expansion on the Hunner lesion.
So it's good to hear from all of you in practical terms. Yeah, sure. Thanks, Quentin and Steve. So in practical terms, like I said, we will follow with a survey to get some ideas together, also agree to be part of consortium or not, agree to be sharing data, then work with the 3 or 4 societies that are currently here, ESIC, et cetera, to develop a chart field for the first initial, the Hunner ulcer type of thing. And if we agree on that chart field, we then create a registry. In the meantime, we work where that registry is going to be. So over the next 3-6 months, maybe a year, we'll have staged plan to do this. So many of you need to think about willingness to share data, willingness to cooperate, and obviously, be confident that your data will not be abused, et cetera. So that's just the process I'm currently thinking, and let's see how we come together. At least we'll strive to do something. All right, so it's time for a break for 10 minutes, and then we have some mini talks, 2 from the industry and 1 from our patient group. Claudia is going to talk to us about a patient view, which I feel it's a fine ending for. And then all the committees are supposed to present a 5-minute summary of their 40-minute discussion yesterday. This 5-minute slide presentation will be repeated at the AUA, and each of the committees can decide who's going to give that at the SIIU session on Monday at the AUA, so that we can share this with the rest of the crowd, whoever attends the SIIU. Okay, up for the coffee.